Hello, and welcome to our listeners around the world. You're listening to JAMAevidence, our podcast series based on core issues in evidence-based medicine. Today, we're talking about the intention to treat principle. I'm your host, Dr. Roger Lewis, Senior Statistical Editor for JAMA and editor of the JAMA Guide to Statistics and Methods series. I'm also a professor of emergency medicine at the David Geffen School of Medicine at UCLA and a senior medical scientist at Berry Consultants. I'm here with Dr. Michelle Detry, who's also an employee of Berry Consultants and the lead author on an article which we wrote together, and you can find a link to the article in this episode's description. So, Michelle, could you go ahead and tell our audience a little bit about yourself?
Sure. Well, first, thank you, Dr. Lewis, for the opportunity to be here and be part of the podcast, and thank you to JAMA. I'm Michelle Detry at Berry Consultants. I'm a director of adaptive trial execution as senior statistical scientist. And what that means is I focus on the statistical implementation of adaptive trials and also have a passion for data monitor committees.
Great. Thank you so much for being here. So, Michelle, in the article that you led, you talk about the intention to treat principle. And before we talk about what that is, I want to take a step back and talk about what we're trying to learn from a randomized clinical trial. So, when we conduct a randomized clinical trial, for example, comparing two drugs in the treatment of patients with a specific disease, what are we actually trying to learn?
Well, ultimately, we're trying to learn which treatment should we use when selecting for a patient. And so we're measuring the intent of a patient receiving something, not that they actually received it or not how much of it they receive. We're looking at the intent of them receiving it. So when we say use a treatment, it's selecting a treatment to recommend for a patient, and then it's actually having the patient receive that treatment.
So, if we're trying to understand the effect of the choice of one therapy over another as our recommendation to a patient with the intent that they receive it, what are some of the pitfalls we might run into when we actually look at the data that is acquired within the trial?
Some of the pitfalls maybe did they actually receive any of the treatment? Sometimes there are situations that happen where patients weren't able to start receiving the treatment. That may happen. There's also adherence to the treatment. Sometimes participants may receive, through various circumstances, part of the treatment, it's like three quarters, one half, but not fully adhere to it or fully adhere to it in the manner that it was intended to be administered according to the protocol.
And I guess sometimes the patient may, for whatever reason, actually end up taking the other treatment before their outcome is assessed.
Yeah, that's true. There are some situations where in a randomized trial, they're randomized to one treatment, and through some situation, they end up receiving the other treatment or a different treatment that wasn't even part of the plan for the clinical trial.
So, if we randomize patients to two different groups with the intent of comparing their outcomes, but in fact, we know that some of the patients never received the treatment we intended them to receive, how should we handle that in a clinical trial? And what does the intention to treat principle tell us about that?
The intention to treat principle says that those participants still, for analysis purposes of the primary efficacy outcome, remain in the treatment group to which they were randomized, regardless of what happened after on. How much treatment they received, whether they completed complete follow up, adhered to the protocol as planned. There are subsequent questions that may be answered as secondary to look at how they compare to the standard primary goal, which uses the intention to treat principle, which may involve looking more at the biological effectiveness, for example, and how much treatment they received. That may be more secondary, more kind of a subset secondary question. But the primary is really looking at the intended treatment. What was the benefit to the patient based upon that, regardless of getting into the details of how much they received or did they receive any?
So essentially, that means that a patient who never took the intended therapy has their outcome counted as being due to that intended therapy anyway. What's the possible rationale for that?
The rationale is to hopefully have an unbiased estimate of the treatment effect. The reasons for which the therapy may not be received could be tied to the ability to take that treatment, do the behavioral intervention, patient characteristics for progression of disease in this population we're being studied. And we're trying to get an unbiased estimate without having all these extraneous factors affecting the study population. So it's really also trying to break it back down to being able to use the concept of randomization, having it balancing the two populations through randomly assigning the treatment assignments. So we're trying to get the unbiased effect and not having all these caveats of, oh, well, this participant did this participant did this. And we start removing and create a non generalizable answer then at the end.
And I think one of the key challenges for people is to realize that we're trying to generate an unbiased estimate of the effect of recommending the therapy, not an estimate of what would happen if everybody could take the therapy or adhere to it.
We focus on the intent because that's where the physician is able to make the recommendation for the patient. The physician may not necessarily be able to control how much therapy the participant takes, whether they take it as planned in the protocol. There may be variation in that according to what the patient actually is able to do or chooses to do. So the physician in their role can prescribe an intended therapy, but they can't necessarily control all the details of how the therapy is adhered to. So the question when coming in and recommending a therapy is really the intended therapy. This is what I hope you intended to, and this is the benefit or the estimate of efficacy that would be at the end. But the physician can't control all the other factors in actually adhering to or taking the therapy. And I think we're also talking more in the later stage trials. There may be earlier trials where you're really looking at, like you said, the biology of this. What did this, if it was a drug for say, what effect did this have on the patient? That's a different question. And that may be answered differently with different kind of analysis populations. But here we're looking at intended therapy, in real world practice, a physician recommending a treatment. What is the likelihood that there would be a benefit to the patient based upon efficacy? And also for help in selecting in the future, do I want to recommend this treatment?
So, if that's the approach taken to understand the effect of recommending one treatment over another, what are the alternative approaches? We commonly hear about modified intention to treat or per protocol analyses. How do they fit into this schema?
They're definitely important and they definitely answer different questions, but supportive questions. Sometimes you will see a modified intent to treat population, which will include basically be a subset of the intention to treat, the ITT population, and be those that received any therapy. And so therefore, you're looking at it comparing, okay, how did the two treatment therapies, if it's a two-arm trial, compare amongst those that received any drug? Or you may have a per protocol population where it's adhering to the protocol without any major deviations. So there you're really looking at for those that were able to adhere to the protocol as planned, the therapy as planned, was this treatment effect efficacious? And I think one of the things we also say with these other populations for safety analyses, I think it's a different question because in that situation, you want to actually look at comparing safety questions amongst those that actually received the treatment. So in a safety analysis, which is often I don't wanna say secondary and diminishing the importance of it because, of course, safety is very important, but is often a different outcome. That is usually in the population that received treatment, which may be a modified intent to treat population. The key is defining these upfront in the protocol so that the reader can understand what the population is in which the question is being assessed.
So, in general, I believe you're suggesting that the primary analysis of a randomized clinical trial should virtually always be the intention to treat analysis. But are there exceptions to that?
Yes, there are settings in which you want to do other than ITT. Often the ITT is the primary and the default, but for example, in non-inferiority trials, you also will want to do a per protocol analysis as a supportive analysis. And the reason for that is because a non-inferiority analysis, you're really looking at two treatments being non-inferior to one another, and I'll use the word similar. And there's a certain amount of how close they need to be considered non-inferior. If you have participants that were not adherent to the protocol, they may often not have the efficacy outcome or not as strong of an efficacy outcome. So, an arm or treatment therapy that may have more non adherence may then have a lower treatment effect, which then could bring it closer to the comparing arm of interest, which then would satisfy the non-inferiority, which was the main question of the trial. So strictly by doing an ITT definition, you could be moving things towards non-inferiority, which is not and doesn't really answer the question at hand. So in that sense, you want to have the ITT be the primary, but then you also want to do the per protocol where you're comparing the treatment effect amongst the patients that adhere to the protocol to see if you have a consistent result as far as non-inferiority. And one of the keys that's gonna tie to this is those kind of participants in the trial as far as non-adherence or missing data, how much of that you have. The amount of difference in these populations is also going to be investigated when looking at the similarity and the consistency of the 2 outcomes. Hopefully, it's minimal. Hopefully, you have complete information. Hopefully, you have good adherence, but this is always going to be a consideration in any clinical trial.
So, in essence, you're saying that we want to use a per protocol analysis just to make sure that we didn't falsely demonstrate non inferiority because in one arm, the patients couldn't take the therapy, and in the other arm, it didn't work and ended up somehow in the same place by those two different mechanisms. Is that fair?
Definitely, that's fair.
Michelle, what are some of the limitations of the intention to treat analysis? And I'd like to focus specifically on the information that we provide to patients to help them make decisions about both what therapies they select and their adherence to those therapies.
I think a limitation is when you do the analysis using the ITT population, you're really getting more an estimate of the average treatment effect across the range of patient participation characteristics. So, for example, what it doesn't do is it doesn't tease out if you're a patient and you were able to tolerate the treatment for, let's say, oncology, the first 2 cycles, what kind of benefit may you have at the end? It's really looking more at the average treatment effect over all those participant scenarios where they adhere to 1, 2, 3, all the cycles. So for patients, it may be difficult then to determine if they want to participate in a treatment or continue a treatment if they're having some side effects that are very undesirable, whether they should stay on the treatment because more treatment or a certain amount of more treatment may contribute towards more benefit. So it doesn't really get at those individual participant characteristics and specifically do an individual prediction. It's looking more at the average treatment effect across the range of the participants that participate in the trial and the true treatment arms in a 2-arm trial.
And I think tying that back to the decision affecting, for example, a physician selecting a therapy for a patient, when you make that treatment selection, you don't know whether that patient is going to be able to adhere. So it is that average effect that influences the selection of the therapy you recommend. But later on, as the patient experiences side effects or not, these other estimates of treatment effect may be helpful in their decision making.
Definitely. And that's why I think there's the full context of all the analyses when a trial reads out should be used, but that overarching question of answering, should I select this as the intended therapy, is guided more by the average than the specifics of a specific individual patient, because you may not have had all those specific situations for the patient that's in front of you that were enrolled in the trial to begin with.
Michelle, in your article, you give a specific example of the use of the intention to treat principle. Can you go ahead and describe that?
Sure. So the example was a trial in patients with anemia and traumatic brain injury. And what the trial was looking at is comparing 2 different transfusion thresholds of 10 and 7 grams per deciliter and the administration of erythropoietin versus placebo. Primary outcome was a 6-month Glasgow outcome scale. And so the trial was comparing the 2 different transfusion thresholds, and what happened during the trial is there was high fidelity where, the patients were able to follow the protocol as planned, but there were a few that did not receive the intended treatment strategy. Specifically, 2 were randomized to the 7 grams per deciliter arm, but they were managed according to the 10 gram per deciliter threshold. And then an additional 2 were randomized to the 7 gram per deciliter arm and then received 1 transfusion not according to the protocol. So, what the authors did is they implemented for the primary efficacy analysis the ITT principle and considered the outcomes for these four patients included in the 7 grams per deciliter group, because that's what they were intended to receive, even though the actual experience was not exactly that as the 7 gram per deciliter group. And the reason they did that was to be able to have the unbiased estimate of the intended therapy and not remove participants that had different experiences than what was intended.
Michelle, what do you think the key takeaways are for our audience?
I think 3 key takeaways are: number 1 is the question of being able to evaluate therapies based upon what the physicians have control over as far as the intended therapy, not what actually happens after that therapy is recommended. So being able to evaluate the recommendations based upon their intended therapy. I think a second one is that the ITT principle is the population that is the definition of the primary efficacy analysis population, where the trial participants are retained in the treatment arm to which they were randomized and analyzed in that arm, regardless of their adherence to the treatment or whether they had any treatment. And then I think a third key takeaway is that in addition to an intention to treat analysis, there are situations where other analyses are very important to have as supportive analyses. And one of those is definitely a non inferiority question where you want to have a per protocol analysis to support the ITT analysis and look for consistency in the results.
Great. Thank you so much for being here. I'm Roger Lewis, and I've been speaking with Dr. Michelle Detry about the intention to treat principle. You can find a link to her article in this episode's description. This episode was produced by Daniel Nassisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.